Hello, everyone. This is Professor TJ Land, and I am hoping that everybody is doing well. I have a presentation that we are going to cover regarding the respiratory clinic, respiratory setup, okay? So respiratory, the biggest thing that's new for you is a little bit of understanding about ventilators and how to manage patient care regarding that. So I've got like 21 of you on the line already, so welcome. Glad to have you. For those that don't know me, I am Professor Land, and I am the didactic faculty at main campus, teaching 421. I want to give everyone else, they have another 5 minutes before we get started. So what I would like to know is there anyone that actually has a question that I can help before we even get started? If so, there's the ability for you to raise your hand, and I will be able to answer your question. Amber? So, okay, Amber, what's your question?
Oh, can you hear me?
I can hear you. What can I do for you?
Oh, sorry. I don't know. I had posted the question before it actually started. I don't know if you can see it.
Oh, that's okay.
I was wondering, in other GC webinars, they have enabled the speaker and mic function so that we don't have to phone in if we don't want to. Is it possible to do that with these, or maybe in the future reviews?
We can consider that. I did not set these up, so I'm not sure how that works.
Okay.
But I will, Amber, make sure that your feedback is well heard, because it would be much easier without me putting this headset on for my phone as well.
Yeah, us too. All right, thank you.
Thank you. If you need anything, raise your hand again. Are there any other questions before we get started, since we have another few minutes? Okay, well, I would like to put another question out there and say we did the cardiac section of exam 1 last week, and I wanted to have some feedback from anyone who participated with that or even utilized the recording once it was posted. Let me know if you are finding them helpful and if there is something that you would like for us to do a little bit different. I do know that there has been a request by some students that we pre-record these and post them so that you guys have them prior to lectures on the content rather than waiting until that week. So you guys let me know what you think. Okay, it looks like I have Caitlin Lee who has a question. So Caitlin, I'm going to unmute you. What can I do for you, Caitlin?
Hey, Professor Land. I just had a question. I didn't get any announcement letting me know that last week's content clinic was posted with like a YouTube access. Do you know if we're going to get access to that, or if we did and I missed it?
It's actually already been posted, but I can, are you in one of my classes, or can you tell me what site you're at?
I'm at Boswell with Professor Creekmore.
Okay, so I will actually make sure, because I know they've had some problems with it, so I will make sure that all sites have that cardiac piece okay?
Okay, that would be great.
It's going to be in the same location that the test-taking one was in. So TLand RN is the channel that I'm on, and all of the things that I do are going to be posted there.
Oh, you know what? I didn't realize that. Okay, I should be able to go and find it then.
Okay, all right. And then I will just, make sure that I share with them that these things need to, it might be good if we made an announcement, okay?
That would be perfect. Thank you so much.
All right. Well, thank you.
Of course.
Okay, so I have another question here. Amber says, we have the PowerPoints posted ahead of time for us. These sessions are reviews, so pre-recording will not allow us to interact and ask questions. So is that important for you, Amber? I'm thinking it is. Lauren says, Professor Creekmore posted that link in the class forum under week 2 in order to answer Caitlin's question. Thank you. And Amber, you say you do believe it's important. Okay, thank you. I will make sure that I share that concern. Please know that you can call and ask questions or contact your faculty and ask questions through your LoudCloud LMS anytime you feel like you need to. That is what the QFI is for. And I know all of the faculty instructors, and all of them are approachable. So please don't hesitate to reach out to them if you also have questions. Okay. All right, so we are ready to roll. I want to go ahead and get started. I want to know, I hope you guys can see my presentation. Okay. So we're going to start off talking about some of the things that you need to have in your repertoire, things that you already know about from Med-Surg. Because there's not a whole lot that I'm going to teach you that is actually new stuff. A lot of it's refresher, but I'm also going to have you think about it in a new way, like the emergency kind of way. So our objectives are just 3. So you need to be able to outline the actual nursing process and the management of care for those who are experiencing acute respiratory distress or acute respiratory failure. Okay, these distress situations are like exacerbated asthma, COPD kind of issues, which includes being able to differentiate between chronic bronchitis and emphysema, because they're in the same category, and the only real difference between them is the fact that emphysema, you get bony structure changes. You actually have a body structure change, and that's really the only difference. And then, of course, PE. All of those you learned about in your previous Med-Surg foundational class. The other thing is to describe their nursing management of clients in a variety of respiratory modalities, including the mechanical ventilation. Now, that piece is new for you, and I have a lot of information for you on that one. The other part is the physiological concepts and the indications regarding chest tubes. So that is a refresher for you. And one thing you need to be aware of is that anything that you've had is fair game for this course's examinations, because it is all about you being able to apply your knowledge to help out patients and to make a difference in a patient's life. So anything you've had is fair game. So please remember to refresh yourself on chest tubes in addition to the basics of the respiratory system. So I'm just going to say these are some key significant things you want to refresh yourself on. Respiratory, the anatomy and physiology, and of course the pathophysiology. Because if you can remember the anatomy and physiology and the pathophysiology of why something happens, you have a better opportunity to understand what you can do about it, or understand why what you're doing about it will make the difference. Okay? ABG interpretation. So you need to be able to be able to interpret ABGs, determine if it is respiratory failure or just respiratory distress, if it's a mechanical ventilation failure, or if it's just a gas, a BiPAP level of failure. So you need to be able to pull that information from your file cabinets from before. Various types of airways. So we've got oral airways, we have nasal airways, we have tracheostomies, we also have endotracheal tubes. So all of those airways, you need to be aware of what they are, how they are utilized. Okay? Again, I'm talking about things for you to refresh yourself on as far as pneumonia, the asthma, the COPDs, add pleural effusions, and the pneumo and hemothorax in addition to your PE. And then from your basics, remember your oxygen delivery chain. So we start out room air on 21%, and so if I go to like 3 liters, how much oxygen is that? And then after I maximize my 6 liters on nasal cannula, I go to simple face mask. And when I can't do that one anymore, I can actually go to a Venturi mask, where I can actually adjust for a percentage of oxygen. And when that doesn't work anymore, then my last option is to do a bag valve mask or an ambu bag at 100%. And if I am at that point, then I need to consider 100% oxygenation on a ventilator, and I would need to have an intubated patient to be able to do that. So let's talk about intubation for just a moment. Well, why would we want to intubate somebody? Well, remember, when we first start looking at patients and trying to figure out what's going on with them and to help them, the first thing we look at is airway. If they have an airway that is patent, we check to see if they are using it. Are they breathing? If they are breathing, then we move towards other things, circulation. So, of course, the first 2 components are airway and breathing. If I cannot protect someone's airway, or they actually have an airway blockage, some reason, be that anaphylactic reaction and now we have swelling, be that the tongue has now been pushed back into the throat, or they've swallowed their tongue and they have occluded their airway, for whatever reason, I may need to establish the airway. And then once I have an airway, I may need to just protect it. So protecting it might be if I have someone who is recovering from an overdose of medication, they are very somnolent, and I am unable to give them enough narcotic reversal, Narcan, or even Romazicon for the others. I can't get enough of that in them to reverse the medication, then that means their metabolic consumption of that medication has to occur for filtration before I will be able to stop worrying about their protection, because not only do I worry about them breathing, but I also worry about them having gastric aspiration. Just because there's an endotracheal tube balloon does not mean that fluids and liquids that come up don't have the opportunity to get down, because they can slide down beside. Remember, that balloon is soft, and so it can trickle down the side. And needless to say, that will then cause us respiratory infections. And we'll talk about that some more. Anytime you are intubating a patient, you are not able to rely 100% on that and connect them to a ventilator until placement has been confirmed. And you will do that by all of these components. It's very important that you remember that you can't use just one. You must use all of these components. So the first thing is you're going to look for chest rise and fall. You're going to listen in all 4 quadrants of the chest. And then you're going to listen over the stomach. Okay? You're also going to use something called an end-tidal CO2 device, which is a little litmus test container that goes on the end of the endotracheal tube, and it's purple, or a dark, dark purple. When they take a deep breath and blow out, if there's CO2 in that exhalation, then it will turn bright yellow, and you are in the proper place. The last way we confirm this is by chest x-ray. Because once we know it's in the right place and everything, we need to know where is the tube sitting in relation to the anatomy and physiology. One of the words that you guys may want to try to look up and remember is the carina, which is where your bronchial trees separate into a right and left. Okay? The carina is right there at that junction. And that's typically, we have the end of the endotracheal tube just a few centimeters above that. We don't want it riding on that carina because it's painful. It's shoving the end of that tube onto that edge of the bronchioles, and very painful and can be very problematic. So let's talk about some collaborative care. It's not just nursing care anymore because it is collaborative. Before we intubate someone, we must confirm that we have all of our equipment, including suction, ready and prepared in an appropriate working order so that we can utilize that. Once we intubate someone, or even before we intubate someone, they may throw up, and we need to clear that out so we can see the airway to try to intubate. So we want to always have that available, that suction working and available. You need to pre-oxygenate the patient prior to intubation. Typically we give them medications, which is the next one, administer medications for the intubation, and that allows us the opportunity to use a bag valve mask. Sometimes you will hear that referred to as an AMBU mask. We have the opportunity to pre-oxygenate using that when patients are sedated. They tend to fight that device when they are not sedated. Once you have the tube in place and you've gone through all of your checks and everything else, then what you need to remember is that the ongoing care needs to include the fact that you do provide good oral hygiene. I've shared with some of my students that the dog mouth has less bacteria than a human mouth. So if we do not help them with their oral care, which includes brushing their teeth, then we have colonization of the mouth, increasing the risk of the bacteria. And so good hygiene is extremely important, and I will tell you, in one of the places in your book, you'll hear about VAP, ventilator-associated pneumonia. One of the key components to preventing ventilator-associated pneumonia is to do good oral care, not just oral care, but good oral care at least every 2 hours. The endotracheal tube needs to be repositioned from side to side on a 24-hour daily basis, because just like anything else, it actually can break down the tissue that it is up against. So we don't want it to stay there for any real length of time, causing damage. Again, if we're going to need to suction someone, we need to pre-oxygenate them before we start sucking their air out of their lungs. So pre-oxygenate so that we actually don't cause a deficit for the patient. On the act, you can do that with an AMBU bag or a bag valve mask. But there's also now, with the higher technology, there's a setting on the actual ventilator where you can push the button and it moves to 100% for suction pre-oxygenation. So you can actually utilize that, and it makes life just a little bit easier. Now, you need to note the markings on the tube at either the lip, the gum, or the nares, if it's in the nose, so that you can ensure that that position has not changed throughout your shift and that the position is being maintained. The reason I say these are collaborative is because cardiopulmonary or respiratory therapy are going to be key components, key partners in this treatment plan, just as much as pulmonologists are. Okay, they are going to be pre-oxygenating with the pre-intubation. They're going to be, they actually are the ones who have taken over the repositioning of the tube and retaping it. Now, suctioning, that is a shared responsibility between nursing and respiratory therapy. The markings, being ensured that the position is being maintained, is also a shared duty. So that's why I say it's collaborative, because it is not just nursing that does this. And we do need to work as a team. So we talked about pre-oxygenating prior to suctioning a patient. Okay, so how would I know that my patient needs suctioning? Well, one of those is they're probably going to get restless. They may have a decrease in their SAT, but if you do it early enough by looking for secretions that are like going up and down or rocking in the endotracheal tube, that's a sure sign. Let's get that out of there. You can also listen to your chest, your patient's chest, and listen for crackles, rhonchi. If your patient's coughing, there's a good possibility they're trying to get something up. Well, the problem is if they are on a ventilator with an endotracheal tube, they can cough all they want to, but as soon as it gets up, there's nothing keeping it from going directly back down, because the tongue is no longer functionable once we have an airway in. Okay. One of the other things is a mucus plug. If they have a mucus plug, you're going to try to ventilate. If you are unable to ventilate, then you're going to try to do a bag valve mask. And you're going to try to, if you are not able to ventilate, you are actually going to ventilate as hard as you can, and you're going to try to get that mucus plug to go down into the lung area to open up the airway. Now, if you can actually get a mucus plug out, that's great. But in an emergency situation, when your patient's turning blue, trying to take time and get it out is not always the best option. Please know that it is mucus, and it is something that the body reabsorbs, and down in the lower portion of the lung, it will hamper oxygenation very limitedly. The other component to that is if there is significant mucus plugs going on, then your pulmonologist needs to know about that, because he may want to do a bronchoscopy on your patient to help alleviate some of that.
Excuse me, TJ, I'm sorry for interrupting. This is Stephanie.
Hi.
Hi. Do you have a PowerPoint to show on the screen by any chance?
It is showing.
No, it's not. I had a student contact me, and they can't see the screen, so that's why I thought I would
I'm so glad that you reached out.
Excellent. I can see it now. I don't know.
I didn't. I thought I pushed the button. Apparently, I did not.
Okay.
We have not gone very far. I'm just talking about indications for suctioning.
Yeah, that's okay. I just thought I would pop in and let you know, and you know, you can.
Thank you very much.
Greatly appreciate it. All right. Thank you. Hi, everybody.
Bye-bye.
Bye.
Okay, so I apologize for that. For those of you who are not able to see my presentation, I'm hoping that it is visual. You can see it now. Okay, so peak airway pressures is a specific monitoring capability of a ventilator. And when you cough, you actually increase the intrathoracic pressure of your chest cavity. And that is a peak airway pressure. That is an airway pressure. And what we do is we actually see what the patient's trend is, and then we set that airway pressure alarm for like 10 or 20 millimeters or PSI above that, so that if that happens, if we start getting that alarm, we know that we are having an alarm of high airway pressures, and we need to go check it out. Typically, it is usually the suctioning of a patient that is the cause of peak airway pressure issues. Another might be that the tube gets kinked, or maybe a lung collapses, or we start progressing into ARDS, which we will talk about a little bit later today. Another thing might be a decrease in tidal volume. If I have fluid and stuff like that down into the lung, it will actually take the place of the ability to exchange gas. And if it's taking up space, then I cannot get enough oxygen air in. So I can measure my tidal volume on my patient on volume modes of ventilation. Of course, hypoxia being the saturation. If you see any signs of desaturation or circumoral cyanosis, or even a delayed cap refill. Those are all signs of hypoxia. Remember, one of the very first signs of hypoxia is restlessness, and then that leads into confusion. So let's talk about suctioning just a little bit more. Oral suctioning, of course, means that we are getting things out of the mouth or the posterior oropharyngeal area. Nasotracheal suctioning is actually a sterile procedure, and I will tell you we no longer use the flexible red rubber catheter. For people who we are suctioning frequently, we do try to go get that red rubber catheter because it's less harsh and causes less trauma to the nasal mucosa. But they come in kits, as you've practiced with already, pre-made kits, and it's kind of like a hard plastic tube. We actually pass that through the nose into the nasopharynx area. Now, please remember, if you're not using the soft red rubber catheter, these stiff ones actually do cause and scratch the mucosal lining of the nasopharynx area every time you insert them. Okay, so one of the ways that you can, if you can't get a hold of a red rubber tube, you can actually place a nasotracheal airway, and you can actually utilize that airway as your entrance in and out of the patient's nose and decrease the amount of trauma that you're getting or creating. So endotracheal and tracheostomy suctioning. Please remember that this is also sterile, but it has a sterile sheath on it, so that once I feed this into the patient, I'm able to push the suction, trigger the suction, and then pull back, and it pulls back into that sterile plastic sheath, and so it's still sterile, and I can use it again. Those inline suction catheters are good for a minimum of 24 hours, and I believe they go 48. One thing of key component I would like for you to be aware of is that quite some time ago in nursing and in respiratory, we used to take normal saline and we would actually instill that into someone's endotracheal tube with the thought that we were thinning down thick mucus so that we could get it out better. Research has shown that that's not the case. Really what we're doing is we are just getting the saline we put down back. We're not actually thinning any kind of mucus, but we did try to drown our patients every time we did it. So it is not evidence-based to continue to instill fluids into prior to suctioning. So if you see that, that's not evidence-based. So manual ventilation, I've already alluded to that. That's the AMBU bag or the bag valve mask device. The force of your squeeze equals the tidal volume. And so tidal volume is the amount of air that is being delivered into the chest. If I do a huge, both hands really hard, then I'm going way overboard for the tidal volume. You don't need to do that. That bag is big enough that a one-hand squeeze will deliver sufficient tidal volume to an adult. Over delivery or over forceful collapse of the bag actually just causes air the extra air flows down into the esophagus, into the abdomen, into the stomach, and it causes gastric rise, and eventually that will cause the patient to vomit. And then we have to worry about aspiration. So just be aware of the fact that, don't you let your adrenaline in the code situation make you overexpand the patient's lungs. Please know that the force and rate is equal to the amount of peak flow, and the number of squeezes that you do per minute actually ends up being their respiratory rate. So the force and rate, putting force together with the rate, is how we figure our peak flow. But we have to remember that our force is not something that we have to be overcompensating for because it's in a bag. One of the key components is before you squeeze the bag again, you need to ensure that complete exhalation has occurred. Because if you don't, then we have something called stacking their breaths. So that means if I give them 500 mils of tidal volume for each of my squeezes of my bag, and I only let 250 out, that means the next 500 I put in there, now that person has 750 in there. And I only let 250 out, and now I'm giving another 500. Uh-oh, now I've I take the risk of blowing up their lung too much, and just like a balloon, if you blow it up too much, it can pop. So we have to be very cognizant of allowing complete exhalation to happen between the breaths that we give. One of the ways that we ensure that we're going in the right direction is to actually watch the chest rise and fall. And again, we have to watch for that abdominal distension in case we are over-breathing the patient's lungs. Okay, so let's go a little bit into something called acute respiratory failure. This is one of the things you might have heard about in med-surg, but it is something that we are going to go into in more detail for you in this course. So this is where your ABGs really matter. Remember, we have a PaO2 reading, which is the partial pressure of oxygen in the artery. And then we have the PaCO2, which is the CO2 reading of the partial pressure in the artery. And then, of course, we have pH. 735 is the low, and 745 is the high of our, quote, normal range. 7.40 is mid-range. Anything less than 735 is considered acidosis. Greater than 745 is considered an alkalosis. So one of the things is if your patient gets into what we call the 50-50 club. So if my oxygen saturation of arterial blood is 50 or less, I must really be concerned about my patient. But if I am measuring that and I also see that my CO2 is now 50 or more, then I have to consider that my patient is looking at respiratory failure because I'm not getting effective oxygen exchange. Remember, I want my PaO2 to be in the 80s, and I want my PaCO2 to be down like around 40. So I want to make sure that I keep those in the proper ranges. Once they cross over and they join the 50-50 club, they are considered in respiratory failure. There are three kinds. There's a hypoxic respiratory failure, hypercapnic respiratory failure, and then there's a mixture of the two. Okay? So let's think about the pathophysiology of acute respiratory failure. This is the information that we get feedback from a ventilator on each breath that the patient takes, and it helps us get that information that we need to know. But what about when we don't have them on a ventilator? Okay? Well, if we don't have, we also have our regular nursing assessment skills. What's my capillary refill? Do I have circumoral cyanosis? What's the color of my mucous membranes? Is my patient restless? Are they beyond restless and now they're agitated? So you have some tools in your tool belt despite the actual ventilator. So I just need you to remember the basics to go along with this information, okay? So the ventilator helps us recognize some pathophysiology issues that might be causing the patient's problems. So I might have an increased pulmonary vascular resistance, which we talked about last week. I might have right ventricular failure, which would be my CVP, which would be high if my right ventricle is failing, which is also called cor pulmonale. I actually can have an impaired left ventricle function, and that would be the left end diastolic pressure, and that would be a PA diastolic or a wedged reading. Well, that then reduces cardiac output. I can also have cardiogenic pulmonary edema. So let's say I've had a severe global MI, and global means that I have hit both ventricles and maybe in a large area. Then things are going to back up, and the first place they back up is to the lung. We also have to be concerned about the diaphragm becoming fatigued because of the increased work that it's having to do to help the patient breathe while they're, getting worse and worse. Intercostal muscles can only do so much, and the diaphragm is the powerhouse behind breathing, and it will fatigue, just like your heart will fatigue. If you are in SVT for any real length of time, it'll just start slowing down because it just can't go. It becomes fatigued. Anybody who's over-exercised, you know that. You can feel your muscles get weak, you feel shaky. The next day you're very, very stiff. All of your muscles can do that, even the ones that are autonomic. So let's take those separately in your assessment. Hypoxemia. Okay, remember that dyspnea is the classic symptom of hypoxemia. Shortness of breath, that's the first one. Then it builds on that restlessness, cyanosis, and those build to confusion, further restlessness and anxiety. We even can get into some delirium. We have tachypnea, and of course, if they're anxious and restless, they're going to have tachycardia. These can lead to hypertension, irritability of the heart muscle, leading to dysrhythmias. And then, of course, if we have delirium, we have the risk for DTs, delirium tremors. And we would rather not deal with those if we already have an oxygenation problem. So hypercapnia, this is generally, there's just a couple here. And headache is one of the big classics. They have dyspnea, but it's more along the lines of the fact that they feel like they're not getting everything out. And then the headache, because there's too much CO2 and there's not enough O2 doing the exchange, you do develop that headache. You can also see some peripheral and conjunctival hyperemia. Of course, hypertension, tachycardia, tachypnea, and of course your consciousness, level of consciousness is going to change. And then there's papilledemia and asterixis. If you don't remember asterixis, please be sure to look that up and refresh your memory on that, because it is something that we will utilize during this particular module, this topics 1 and 2, and exam 1. Okay? So what other kind of assessments? Well, of course, if you do an ABG, it's going to confirm your suspicion of acute renal failure. Sorry, acute respiratory failure. I'm on the kidneys already. Apologize. We can do a chest x-ray and see, because when they do a chest x-ray, they do it on the deep inhalation just prior to exhalation. So we're hoping to see full lung expansion. But what happens when we don't? Well, the chest x-ray may be able to pick that up for us and give us a clue. Sputum cultures. So if we have some kind of respiratory issue going on, we can do sputum cultures to help us make a determination. PFTs, those are those pulmonary function tests that you remember learning about in med-surg. You can do angiographies or even VQ scans. VQ, or the Q stands for perfusion. That's a nuclear med scan. We do those when we're looking for PEs. CT will also help you. Of course, echoes, thoracentesis, sometimes even EKGs can give you some inkling as to what may be happening. If this is a toxicology issue, then a tox screen would be very beneficial. And of course, our always necessary CBC, electrolytes, and UA, because is this patient sepsis, right? Is this patient have enough hemoglobin that it can carry enough oxygen? Is that our problem? Of course, the electrolytes play a part. We definitely do not want mag and potassium to become too unstable, because there's a very small window of what the body likes, and once we get outside that window, the body doesn't care for it very much, and the body's pretty touchy. So let's talk about managing those things. So we either need to correct or compensate for whatever abnormality in gas exchange is occurring. So intubation can be one of those, but if you're going to intubate, you must consider the fact that mechanical ventilation will probably follow. Oxygen therapy on the ventilator the goal is to typically keep their saturations greater than 90%. Now that's pretty significant if you consider somebody that is well, it needs to be greater than 94%. And somebody who's sick and in the hospital, greater than 92%. So if we're in respiratory failure, we definitely need to keep them at a minimum greater than 90%. And the only way we're going to know that is to do continuous pulse oximetry. If these are medication overdoses, so we can try Narcan and Romazicon to see if reversal will help us out any. The other things is, are we having any bronchospasms? If so, we want to work on the bronchodilators and the corticosteroids. One of the questions that comes up is, which comes first, the bronchodilator or the corticosteroid? Please know that it would be the best benefit of your patient to give the bronchodilator to open up the bronchioles so that when they do take the corticosteroid, they get the best benefit of that inhalation. So that actually just covers the acute respiratory failure component. One of the biggest things is we're looking at the 50-50 club, and we're looking at what does our patient look like. We're looking at what does the patient look like and the results of what our ABG says. Okay? Now, when patients are on the ventilator, they are at high risk not only for ventilator-associated pneumonia, or VAP, they're also at high risk for something called an acute respiratory distress syndrome. Now, there are some people who have pulmonary issues that are at risk for this even without the ventilator. So adding a ventilator doubles up their risk. Patients who get ARDS have high mortality rates, and it is a clinical syndrome, either because there has been direct lung injury, like let's say we had a lung contusion when they hit the steering wheel in an automobile accident, or let's say there's a pneumothorax because of a gunshot wound. That is direct injury. The other component is indirect lung injury. That is, okay, this person, we overexpanded their stomach when we were ambuing them, and now they threw up. Well, the indirect lung injury is the fact that they aspirated that, and it is now in their lung, and now we have an indirect lung injury related to what we were doing. We must always remember that there's pathological changes in lung vasculature tissue, especially inhaling hydrochloric acid. Not only is it a liquid going where air is supposed to go, but it's also an acid, and that acid causes damage as it goes. So all the way down the bronchial tree, all the way down into the actual arterioles and into the capillary beds and the alveoli sacs. Once those things happen, we're going to have the autoimmune response is going to kick in, and we're going to start getting increased lung edema, and actually that lung edema will actually cause a further impairment of gas exchange, because all this fluid is coming down there thinking it's going to wash it out, when in actuality it's not. It just increases the risk and the complications of what is already happening with this patient. Our body doesn't know that. This is our normal compensation. So the pathophysiology of ARDS. We actually have a diffuse alveolar capillary membrane damage that occurs. What happens is the alveoli and the capillary bed, they're like intermingled. But when I have fluid that gets in there and covers the capillary bed, then air can't get in there. Because remember, one of the things that makes things easier to remember is that air will float upwards and fluid will go downwards. Well, it's the same in the alveoli sac. Once it gets in there, it's going to go to the base of the sac, and that's fluid. Well, that's where we want our oxygenation and our CO2 exchange to happen, but it can't if it's underwater. That's because the water has caused damage, and it actually starts filling up the alveoli sac. Now, once that happens, that insult happens, the membrane of all the cells in the capillary bed become damaged and become permeable. Permeable means that they become non-resistant to items that should not be going in. Okay, the wall historically can keep things out and let particular things in. Okay, but if it's no longer working properly, then all kinds of things can get in, and so it's not in control any longer. That allows that extra fluid to go from the vascular space and seep into the interstitial space and further into the alveoli spaces and causing even more damage. So your air spaces are actually filling up with either blood, protein fluids, or even parts of the cellular debris where your cells actually rupture. This then complicates things even more. So your inflammatory mediators, right? This is your inflammatory response syndrome. This actually causes the pulmonary vascular bed then to constrict, because it's like, oh no, we're drowning. We don't want that. And so if I constrict what already isn't working, then the part that is working can't function, and that also makes things worse. Once that happens, the progression is that now the lung compliance is reduced, and we actually have an increased airway resistance because of that reduction. And what I mean by that is the lung becomes, the other name for ARDS is called stiff lung. You also might hear it called a white lung. And I'll explain a little bit more about why in just a moment. But if your lungs do not have the elasticity to stretch and relax, then they're not going to be able to do that, contract and relax. Okay, so the less it's able to do that, the stiffer it becomes, especially with more and more fluid in there consolidating. Now when you look at a chest x-ray, when you look at the chest x-ray, you can see the white outline of the lungs and the heart and stuff, but inside the lungs it's all black. That's because there's no fluid in there. That is all air. It is the opposite, because remember, chest x-rays are negative. So it is the opposite when you have someone who has ARDS. They start getting that liquid in the lungs, and you start getting patchy infiltrates. And as those get more and more, they start consolidating. Consolidating means they clump together. And as they clump together, the lung becomes stiffer, less pliable, and we have less ability to have gas exchange because more and more is underwater. Now, if that's the case, then our airway pressure is going to increase because water is heavier than air, and that water is taking up the space, causing increased resistance. When I don't have the flexibility that I need, then that is going to be resistance. And if it's just like a rubber band. If you've ever had a rubber band, a new one, you can actually stretch and it gives and goes and gives and goes back. If you have a rubber band that's been out in the sun for a little while, you actually can pull it apart and then you'll see it starting to crack. And if you let go of it, it won't go back together. If you pull it really good and hard, it actually breaks. And that's what happens to lung tissue in this situation. And so if it can't expand, then it's going to increase the airway resistance. So how is your patient going to present? They're going to present with tachypnea, dyspnea, and you're going to see them using their accessory muscles in addition to the diaphragm in trying to breathe. Their hypoxia will be refractory to oxygen therapy. And really what that means is we can increase, like if we have them on the ventilator and we have them at 50% oxygen, we increase their oxygen, say 60, 70, 80%, but it does not help the patient. That is when you see refractory hypoxemia. You will also see crackles, or hear crackles and bronchi. Arterial saturations of oxygen are going to be the early sign because we're going to get drops in those sats. Lethargy is an even more ominous sign because by that time we already have some, we've actually gone beyond some restlessness and confusion, and now we have moved to the point of being lethargic. That means we have a whole lot more CO2 on board than we expected to have. Remember, with ARDS, there's some specific diagnostic criteria. One of those is the PaO2 FiO2 ratio. Okay, if it's less than 200, and we have bilateral infiltrates, and there's no cardiogenic suspicion, it is all lung, then it is an ARDS situation. They can actually do a bronchoalveoli lavage and get a chance to look at that down there. Serum lactate levels will also help give you a clearer picture of how far along this has been. You actually have the opportunity to evaluate lung compliance and airway resistance once you put them on the ventilator and when they go and do a bronch. ABGs are going to be tools that you're going to use, and then of course your chest x-ray. Now, we're going to do a chest x-ray daily anytime anybody is intubated to confirm placement of the endotracheal tube, that it hasn't been shifting around while we've been caring for them. But we specifically ensure that that happens when a patient has ARDS because we need to monitor the whiteout, the whiteness of how much of their lung is white and how much has black and oxygen in it. And is it getting worse, or are we starting to see more black? Are we getting better? And a chest x-ray is the only way to be able to tell us that. So managing your patient, a lot of what we do is supportive therapy. We do have to oxygenate and ventilate the patient using an endotracheal tube and a mechanical ventilator. We have to be very careful about monitoring circulation and perfusion because not only can circulation perfusion be a problem, but oxygen perfusion can be a problem. And if I put both of these together, I really have a bigger problem. Fluid and electrolytes have to be constantly monitored, and do not forget INO. INO is key. Monitoring patients, mobility and safety, their skin integrity, because they're going to have to be turned every 2 hours. Nutrition, because now we have to have healing to occur. Comfort and pain has to be addressed. Well, with all of this going on, of course, psychosocial has to happen, but not always the patient, because sometimes the patient is actually sedated. Sometimes it's the family that is the focus of the psychosocial. It just depends on what is going on and the specific case, the specific patient, and the specific family. Please remember that teaching and discharge has to start upon admission, and then it's ongoing. And if the patient is sedated, there's no reason why you can't speak with them because they can still hear. Evidence has shown that they are still able to hear and the brain is still working. But you may need to do that with the family, okay? Further management is when we're turning our patients, there's something called the prone position. This is when we actually turn our patient onto their abdomen. Now, this is pretty dangerous because we are moving someone who has an endotracheal tube connected to a ventilator and that's their only way to breathe and get gas exchange. They have a Foley catheter. Typically, they may have 1 or 2 chest tubes due to trauma of the lungs. And they have central lines and arterial lines and peripheral lines, and we don't want any of them to be lost in the turning. So you will never be able to do it by yourself, and you will always really need a minimum of 4 people. We also address this situation pharmacotherapy. We do antibiotic therapy, bronchodilators, mucolytics. Those are the ones that help us reduce or thin the mucus. We also use exogenous surfactant, corticosteroids, diuretics, and then neuromuscular blocking agents. What you do need to know about neuromuscular blocking agents is that when we sedate our patients, if there's like resistance to the treatment, which sometimes there is, to get the best response out of stiff lungs, we sometimes will paralyze a patient. Please know that when they are paralyzed, you must sedate them because it's like a locked-in syndrome. Their head is still awake and they can't breathe, they can't move, they can't scream, but they are screaming in their head. They just can't get you to hear it. So that would be like torture. So neuromuscular blockers, we are then going to sedate. The other piece to that is if I sedate my patient, I also need to have a comfort of pain control, okay? How do I know how much sedation I need to do for my patient? Well, and how much paralytic do I need to give? Well, there's something called a train of 4, and that is a test that's done on a peripheral nerve stimulator. And the train of 4 is you push the button, and wherever you have it situated, either so that it impacts the thumb or the eyebrow, if you get 4 twitches when you push the button, that means they're fully awake. If you push the button, because it always sends 4 impulses at the same strength, if you get 2 twitches out of the 4, you are right where you want them to be. If you get no twitches or 1 twitch, you are way too sedated, way too paralyzed, okay? Another way that this can be monitored in some of the newer ICU that have some of the newer equipment, they're called a BIS monitor, and it actually measures brainwave activity, and you titrate to that brainwave activity number. The one I do want you to remember is the neuromuscular blocking agent and the peripheral nerve stimulator. So if we are on the ventilator, we must prevent any further complications. So the systemic inflammatory response, I've already had that, but if I have it happen again, now I have to be worried about the potential of this turning into a shock state. I have to be worried about ventilator-associated injury, which is called VALI, or even a ventilator, it should be a ventilator-initiated or induced lung injury, which is a VILI. I apologize. Before I post this, I will make sure some of this is corrected. Ventilator-associated pneumonia, of course, we've already talked about VAP. So these are the things that we want to prevent, even though we are doing supportive management of this patient. So the mechanical ventilation, we use this in a lung protective strategy when we are doing ARDS management. We are to use the lowest level of oxygen setting, which is your fractionated oxygen, FiO2, as possible, as low as possible. Tidal volume, and 6 is the average, but I will tell you 5 to 8 is the range. And with ARDS patients, I have seen historically that they tend to use 5 to be on the safe side and not cause pneumothorax. Because how much you're putting into the lung causes a change in the pressure that's in the chest, and it affects cardiac output, among other things. PEEP, positive end expiratory pressure. This is where, on the ventilator specifically, I can actually have a continuous amount of pressure being held inside the lung. And that actually helps us to recruit back alveoli that have been invaded with fluids and then they've collapsed as they've broken down. we get the opportunity to push them open with this PEEP, and then the PEEP actually helps keep them open. That helps us improve the gas exchange. But as we increase the amount of PEEP, we have to drop the tidal volume because of that increasing amount of pressure in the chest. So the big things I want you to remember is the fact that we try to use the lowest amount of oxygen possible. We balance the tidal volume and the amount of PEEP, but we start out on our tidal volume setting typically with a ratio of 5 milliliters per kilogram for a patient. So you will see that here that I have a 7.25 in the 50-50 club. 7.25, that patient will need to be on mechanical ventilation for a period of time. It will not be short-term. Mechanical ventilation allows us the opportunity to put PEEP involved and maintain alveolar ventilation. We can correct hypoxemia. We can correct acidosis, that is respiratory acidosis. We can actually rest the respiratory muscles, and we can actually impact and maximize oxygen transport based on how much oxygen we can deliver them, and we can also measure that with our pulse oximetry as well as our ABG. So there's a couple of things you need to know about ventilators. There are 3 different modes of ventilation, okay? I have volume ventilation. This is where I have a preset of volume of the amount of air that goes in, and then it comes out with every single breath. There's a pressure ventilation mode, which it's preset on the amount of pressure that it feels, and then it stops. No matter how much tidal volume happened to go in, it will not stop until it reaches a certain pressure. So that's the difference between ventilation and pressure, okay? High-frequency jet ventilation are the ventilators that they simulate a panting kind of breathing, and it's usually for those who have ARDS that's been resistant to all other therapies. And you have each lung is individually intubated, a right bronchus and a left bronchus, and each one has their own ventilator, and they pant both lungs. And it's kind of interesting to see, but for the patient, it's a little bit scary because there's no slowdown, there's no downtime. The lungs are constantly moving. So let's look at some of the lung injuries that we have to monitor for. We talked about how those can happen. If I get too much pressure in my chest, be that because I have too much tidal volume and too much PEEP, and I increased the PEEP but didn't drop the tidal volume, then I can have trauma. Barotrauma, that would be that I have too much PEEP, okay? Volutrauma means that I increased the PEEP, but I did not decrease the volume appropriately, and so I blew the balloon too big. I can have atelectasis that causes atelectal trauma. I can have biotrauma. That is an infection of some kind that causes actual tissue damage, and we do have those kind of infective issues sometimes. Again, we go back to VALI, which is ventilator-associated injury, and VILI, which is ventilator-induced injury, and I'm glad I got it right on that one. So we've talked about the ventilator modes. Those are very different than the ventilator settings. So your oxygen setting is your fractured inspiration of oxygen. Your tidal volume is how much you breathe in and out, the amount of air you're delivering with every breath. Of course, the respiratory rate is how many breaths per minute. PEEP is the amount of pressure that can be maintained in the lung at the end of expiration. So as they exhale, there's a certain amount of pressure that is kept in the lung to keep that alveolar sac open. Peak flow, this is how fast the flow of gas is going through the system. And then your inspiratory pressure limit, or a high pressure alarm, that's the one that you're going to monitor for patients that are coughing, maybe a buildup of secretions, maybe I have a kinked tube. So those are the things that you're going to monitor the high pressure alarm, that inspiratory pressure limit, okay? There's also the sensitivity. So if the patient's trying to breathe and they can't, then that ventilator is not sensitive enough. If they're not trying to breathe, but the ventilator still tries to give them a breath because it's picking up on cardiac activity, then it is too sensitive. So that's what we mean by the sensitivity, okay? How hard the patient has to breathe to trigger the breath. Then there's something called inspiratory-expiratory ratio. We call it an IE ratio. So what we do is if we have 1 second of inspiration, we have a 2-second exhalation because it's a passive thing. Inhalation is a driven thing, but exhalation is passive. So we have to give it more time. Normal is 1 to 2 or 1 to 3. I can tell you that we have increased that for people to have longer periods of time for full exhalation. We've also reversed them or inversed them to allow for periods of improved oxygenation, longer inspiratory times to help with oxygenation with those who are resistant to getting enough oxygen into the system. So these are some kind of modes. Assist control and SIMV are the 2 kinds of volume, okay? Assist control is the one that has the most control. The respiratory rate and the tidal volume is preset. The patient can take their very own breath extra above the set rate, but if they do, they will get the preset amount of volume. Synchronized is different. It has all the same thing, except for that if the patient triggers a spontaneous breath above the rate that's set, then they can pull however much tidal volume they want. The tidal volume is not guaranteed. So if we're weaning a patient off of a ventilator, we would move from whatever the setting is, or say it's assist control, then we would move to SIMV before we move to CPAP. Okay? Looking at pressure modes, we're looking at having peak inspiratory pressures being what is set so that the ventilator delivers that pressure and then stops. And so you might hear the ventilator going, psh, psh, psh. It will actually immediately cut off when it reaches that pressure. So the respiratory rate, the inspiratory rate, and the IE ratio are set, just like on the other one. What is not set is the tidal volume, because we are doing everything by pressure within the chest. So tidal volume is going to vary because it depends on how much pressure it is for each individual breath. Some pressure modes would be like pressure controlled ventilation, pressure support ventilation. I will not ask you anything about an inverse ratio. We already talked about it, but we don't really do a set inverse ratio setting anymore. And then, of course, we have airway pressure release ventilation, and that just gives us a little bit better timing of alarms and pressure amounts during inhalation, okay? Volume guaranteed pressure, I don't see that happening anymore. But CPAP and BiPAP, you should be able to remember those from MedSurg. With CPAP, remember, that provides a constant pressure throughout inspiratory and expiratory cycles. Okay, it's a constant flow. With non-invasive bilevel, this is the same thing, but I have the ability to bleed in oxygen. I also have the ability to provide pressure on inhalation and even a different pressure on exhalation, which is PEEP. I can actually put PEEP on this. So if I am in OR and a patient comes out to PACU and they're extubated and all of a sudden I can't keep them awake, rather than re-intubating a patient, I might try this non-invasive BiPAP because I can do everything I can do except for they need to take their own breaths. So I can actually do that if I use a bilevel positive pressure. It's easier for them to do that because it has the continuous flow, and I have an inspiratory and an expiratory pressure that assists them. So least invasive would be a BiPAP. If that doesn't work, then it's re-intubation. Looking at nursing care, these are basic nursing care, right? Maintain the airway, monitor the vital signs, which includes arterial oxygenation, saturations, mental status, respiratory status. Also, you now have to monitor your ventilator and its alarms. You have to suction your patient as needed. Make sure that you pre-oxygenate. And then you have psychosocial support. Now, nasogastric suctioning is where we go through the nose into the stomach and suction out that content. Orogastric just means I went through the mouth into the stomach. Okay? We need to check the endotracheal tube cuff because anything that causes pressure can actually cause a pressure sore. And so that cuff inflation, that will be checked every shift by the cardiopulmonary or respiratory therapy department. But you are more than welcome to read his chart and see what measurements he got just to ensure, trust but verify. We always want to keep the head of the bed up elevated at 30 degrees. This will help us in the prevention of ventilator-associated pneumonia as well as VAP. Sorry, that is VAP, as well as aspiration pneumonia. We already talked about oral hygiene. We already talked about nutritional support, right? We need proteins for healing, and we need carbs for burning all the extra energy for healing and to prevent the use of proteins for energy. Now, when patients are in this kind of a situation, we must also remember the fact that if you are unable to blink, you are unable to have your liquid tears bathe the eyeball. And once the eyeball starts drying out, you start getting permanent damage. So when I say eye care, we're actually talking about, just like when you do with a baby, you put the antibiotic in their eye with that little, along the bottom of their eyelid. We do that with something called Lacrolube. It's just a gel of tear formulas, and we put that in their eye because they can't blink. Their eye stays closed, but they can't blink. Some of you who have recovered patients in the PACU might see your patients come out with that greasy, jelly eye look. That's what they've done. I kind of talked about weaning from the ventilator. We have to make sure that all of us are included, nursing, pulmonologist, the regular physician, and respiratory therapy, and the patient, okay? There are standardized weaning protocols for every facility. You need to ensure that you are following those protocols. Critical pathways means that the patient is ready. He has met all the criteria to be trying to extubate them. We typically try to wean them in the morning after they've had a good night's sleep, and there's usually more people there in the morning than there are in the evening, so it's just a safer time to do it. We still want to medicate for comfort, but please remember, some of our medications cause respiratory depression, and if we're trying to wean them from the ventilator, that will not be beneficial, all right? We want to raise the head of the bed from 30 degrees up to at least 45. And then, again, this is going to be frightening for the patient, so giving them support and reassurance throughout the process is going to make a big difference for your patient. There's different ways of methods of weaning. We used to do T-piece. Most of the time, we actually do SIMV and then CPAP, okay? And here are my references. I hope that you have enjoyed the information. Thank you for attending, and I look forward to meeting with you again next week. Thank you all.